The following episode is brought to you by the American Urological Association. This episode comes to you from the AUA 2024 instructional course, Upper Tract Urothelial Cancer Guidelines, an interactive and evidence-based course highlighting the full spectrum of disease via case discussion and video presentation. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by Merck & Co. Inc. and UroGen Pharma Inc.
First of all, just on behalf of the faculty that's here today, just thank you everyone for coming for our course on upper tract urothelial carcinoma. We've got a dynamic faculty here today that's going to go over a lot of the details about this complicated disease with you. And what we want this to be is a very, very interactive course. So we're very interested in getting feedback from you. We want you to use the microphones. We'll talk about that a little bit more in a moment. So general welcome and instructions. AUA policy states that all planners, authors, and presenters must disclose to the AUA prior to their presentation any and all relevant financial relationships with any ACCME-defined ineligible company, formerly known as commercial interests. The AUA determines if the relationships are relevant to the educational content and mitigates any conflicts of interest prior to the education activity. Disclosures or relevant financial relationships are posted on the AUA's annual meeting site, which is aua.org/annual meeting, and a link is posted in the mobile app. All right, so let's go on to, we'll start the course, and we're going to start with just an intro slide, a set of slides before we have Dr. Trong come up. And I'll try and keep this as brief as possible. So first of all, I just want to thank everyone for coming in. This is a very challenging field to work in, and I think the more information we can share together about the management options for patients with upper tract disease, especially based on the guidelines, the better off it will be for our patients overall. And we have a tremendous panel of experts here today, so please feel free to come and ask questions. As far as, I don't think this is working. I'll use this. Okay. So we have really no relevant disclosures other than clinical trials that many of us are involved in. This is the course outline. I'm going to keep this very brief. Essentially, we'll go through this intro here, an initial evaluation and diagnosis and risk stratification for patients with upper tract disease, endoscopic management, including tips and tricks and troubleshooting for that. Multidisciplinary care, which I think is a growing area of what we're doing now in upper tract cancers to include our colleagues in medical oncology. And there's a lot of new data involving upper tract cancers that you'll learn today. We'll talk briefly about the surgical management, follow-up of patients after managing upper tract disease, and then a little bit of future directions at the end. This format is going to be case-based, so hopefully this will be stuff that helps you get sort of engaged in the subject matter, because we'll be talking about patients with actual disease and how we manage them. It is minimal didactic, so we're going to be giving you some information, but most of this is coming from the AUA guidelines, which you should have gotten as part of your reading materials beforehand. We'll present cases followed by discussion, management options, and if you have other questions, please come and use the microphone. And we enthusiastically encourage you to use the microphone. So even if you don't want to come up and talk, just you can shout out. We'll repeat the questions that you ask here so that people at the audience at home can hear them as well. These are the source reading that you're going to have. This is the recently published AUA upper tract guideline, the first upper tract guideline that we've put through the AUA. And so it was put together by this really all-star panel of people that gave a huge amount of their time to put this guideline together. It was a monumental task to go through all the data. And if you'll notice the people that are here on this slide really just know this field inside and out and did everything they could to put together a really good and effective guideline for managing patients. So as far as background, just a brief few slides on background for upper tract cancers. First of all, it's a rare disease. I think we all know that. Less than 7,000 cases are found each year in the United States, and this is a disease which is more rare than testis cancer. And what's interesting, you'll notice, is that testis cancer is something that is regionally, managed by many small centers, and yet for patients with upper tract cancer, many of us feel comfortable trying to manage these patients. But you have to understand the complexity of this disease can make it very challenging to make sure that you get good outcomes for your patients. So I think many of you that are here today are to hear us share some thoughts about how best to manage this process. Exposures such as smoking, prior history of bladder cancer put you at risk, radiation exposures, chronic inflammation, chemical exposures that are listed here, and most importantly, hereditary cancer syndrome. So Lynch syndrome is something you're going to hear about over and over again today. It's something you need to kind of drill into your head about patients with upper tract disease. When we talk about upper tract disease, why is it different from bladder cancer? There are genomic differences between upper tract cancers and bladder cancers. I'm not going to dwell on those. We're not going to go into a lot of the genomics of things today, but you should also know that there's an embryologic difference between upper tract and lower tract disease. That embryologic difference is here, and that is that the ureter and the renal pelvis develop off of the mesoderm, which is different from the endoderm, which makes up the cloaca where the bladder is developed from. So even though the urothelium is the same, they are different embryologically, and that may be a difference in terms of why we see some differences in the genomics of upper tract cancers and lower tract cancers. Some of the known causative risk factors, such as Lynch syndrome and aristoloic acid, seem to affect predominantly the upper tract. Why that is, no one really knows for sure, but it may be an embryologic phenomenon. We don't know. As far as things like risk factors that will impact a patient's outcome, it really comes down to things like grade, stage, and hydronephrosis. We should know the staging of upper tract cancers, which are listed here, very similar to what we see for bladder cancer. This is the impact of hydronephrosis on a patient's overall outcome. If you have a disease that's obstructing your ureter, that usually means that it's an invasive disease or it's a very bulky cancer that's obstructing the ureter and causing hydronephrosis. It has a poor prognostic impact on survival. This is data that I call sort of the pre-chemo data. This is historic data that came before we were giving a lot of chemo to patients with upper tract cancer. If you are endeavoring to treat cancer of the upper tract without using chemotherapy, either in the neoadjuvant setting or in the adjuvant setting, these are the results you're going to see. When a patient walks in your office and has high-grade upper tract cancer, I tell them there's a 50% chance that you will die of this cancer in the next 5 years with surgery alone. So I know that you're anxious to get your kidney out right away as soon as possible. However, if we do that and you can't get chemotherapy afterwards, there's a good likelihood that you'll be dead in the next 5 years. Once they hear that information, that usually sort of helps them, tether their enthusiasm for surgery right away and helps us to think about other options that are available. And then this issue about cytologies. So you should just know that there's a new classification system. It's not that new, it's been out for a while, but it's the Paris classification system for cytologies. People always wonder, well, what does it mean for atypia? What does it mean, if I've got suspicious cytology? High-grade cytology is the one that is probably the most closely associated with risk for higher risk cancers of the upper tract. But these are the new classifiers for cytologies that you all need to be aware of. And you'll hear more about it later in Dr. Truong's talk, which is coming up next. So with that, I'll hand things over to Dr. Truong, who's an expert in upper tract disease and practices at Hershey, Pennsylvania. And hopefully you enjoy her talk. Thanks.
Okay, good morning, everyone. This is the overview and objective of my talk. I will go over the initial evaluation of upper tract tumor, standardized reporting of endoscopic evaluation, technique for biopsy of upper tract tumor, risk stratification, which will set patient on the course of their treatment, and genetic evaluation in patient with upper tract cancer. So I will start with a case. This is something that urologists not infrequently see. The patient come in with chief complaint of intermittent gross hematuria. Patient is 65-year-old woman with intermittent painless gross hematuria for 2 months. And these are the components of a complete history that you should elicit from patient at the initial evaluation. Medical history, including whether or not they have prior chemotherapy, radiation, history of bladder cancer, right, recurrent urinary tract infection, surgical history, social history. Did they smoke? How long did they smoke? When did they quit? Occupation and exposure. We know that certain occupation can expose patients to urothelial cancer development, such as those with exposure to petroleum dye, paint, right cleaning chemicals. Family history is very important in the evaluation of patient with upper tract cancer. Their ancestry, do they have Ashkenazi Jewish ancestry? Are they from the Balkan Peninsula, where that's relevant of, aristocratic acid, 3-generation pedigree. That's not just whether or not they have any GU cancer, right? You're not really asking them, oh, do you have prostate and kidney cancer? Well, you know that they don't really go together. You really want to know, well, do they have family history of colorectal cancer, endometrial cancer? What's the age of onset for those? Type and stage of cancer that the family have, age of onset, and their lab, which will guide you on what imaging that you can get. So back to our patient, 64 years old woman, have history of HIV, Hep C, severe scoliosis, which you will see, chronic thrombocytopenia. She never had surgery before. She's Hispanic. Her father have history of prostate cancer, but she doesn't know much more than that. Mother with cancer of unknown origin. 2 sisters with breast cancer diagnosed at 57 and 62 years old. She smoked 2 packs a day for 15 years. She quit about 40 years ago. She worked in clothing warehouse, live alone with 2 supportive family member, her daughters, and she had baseline good renal function. So what's the next step here? This is just a typical gross hematuria workup, right? So guideline statement number 1, for patient with suspected upper tract cancer, really gross hematuria, a cystoscopy and cross-sectional imaging of the upper tract with contrast, including the delay imaging to evaluate the collecting system should be performed. And CT urogram is typically preferred if there's a reason why they cannot get CT scan, like a severe contrast allergy, renal insufficiency. They can get MR urogram, or they can also get CT abdomen and pelvis without contrast, and you can perform bilateral retrograde pyelogram at the time of cystoscopy. Otherwise they can also get a renal ultrasound. Now it's important to keep in mind that at the time of presentations, about 17% of patients with upper tract tumor also have concurrent bladder tumor as well. So this is her CT scan. She have, as you can see right here in the, there you go. She have a like mid to distal ureteral tumor, pretty bulky, enhancing, and then she also have some suspicion for bladder tumor as well. So I took her to the operating room, did a cystoscopy. This is what her bladder tumor looked like, and did a right ureteroscopy and see a right obstructing ureteral tumor. So first question to consider is, what do you investigate the contralateral side at the same time? So just a show of hand, how many people would also do ureteroscopy of the left side? Good, excellent. So guideline statement number 6, I'm going to go out of order here, but it just kind of reinforces some of the concept that the guideline recommend as we go along through this case. At the time of ureteroscopy for suspected upper tract cancer, clinicians should not perform ureteroscopic inspection of a radiographically and clinically normal contralateral upper tract. Why is it? Well, you don't want to seed the tumor into the contralateral kidney if there's no evidence of it being affected. Second question is the management of bladder tumor. What do you do at the time? Statements say in patients who have concomitant lower tract tumor, either a bladder or urethral cancer discovered at the time of ureteroscopy, the lower tract tumor should be managed in the same setting as ureteroscopy. But the order, that it doesn't talk about the order of how do you manage the upper tract or the bladder tumor. So just a show of hand, how many people would do TURBT, remove the bladder tumor before they investigate the upper tract? Okay. And how many people would do the upper tract first and then do the bladder tumor second? Okay. We have 2 urologists on the panel. What do you do, Dr. Coleman?
Yeah, this was actually an area of some controversy when we did it on the guidelines, and there were a lots of recommendations or reasons for one or the other, but I typically do the bladder first before addressing the upper tract. My reason for that is that if you do the upper tract first, sometimes you get bleeding. That makes it hard to see the bladder tumors, and sometimes you can't do a good job with the TUR. Also, if I leave a stent after doing the upper tract tumor first, and then you're doing a TUR of the bladder, you could potentially wash cancer cells back up, or transmit some of the pressure from the bladder into the upper tract. So I usually do the upper tract first, but some people do it the other way around.
Dr. Rahman, do you do the same order, or do you do something different?
Mostly just from a visualization perspective, to be honest. It's just once you do upper tract work, the bladder is just always has this constant ooze coming down. So I do the bladder first.
Okay. Statement number 2, clinicians should evaluate patient with suspected UTUC with diagnostic ureteroscopy and biopsy any identified lesion and cytologic washing from the upper tract system being inspected. So the question is, how do you biopsy the tumor? What's the do you do endoscopic ablation? What are the different methods of biopsy? There's numerous approaches depending on the patient factor and depending on the tumor. You can in terms of endoscopic approach, you can do antegrade, getting a percutaneous access and approach it from the kidney, or do rectograde evaluations. And the technique, you can do brush biopsy, right? You can use a brush and get some cell, and same for cytology. To that way, you can use the Parana forceps, which is right here, as you can see, small forceps. But if they are like a thin stalk, that would be ideal. Flat wire basket, I actually like this approach for more larger bulky tumor, because as you can see, you can get a pretty good chunk of tumor without really much risk of ureteral perforations. And you can same both for cytology and also pathology, which will be important when we talk about tumor testing for like immunohistochemical staining. And then if it's like a low papillary small tumor, you can do laser fulguration, which Dr. Rahman will talk about some of the technique and the laser setting. And finally, you can also do selective cytology and washing up the upper tract for the tumor. Just out of curiosity, how many people use the flat wire basket here? Okay, and Parana forceps, laser. How many people, if you see an upper tract, if you see a tumor, you just get cytology? Okay, yeah, thank you. So Dr. Coleman touched on the Paris system for reporting urine cytology. It's a range from non-diagnostic to negative cytology. Atypical, which, for me, atypical, you have to know kind of what the data from your institution, meaning that what does your pathologist typically call atypical cytology? Is it more frequently a negative cytology, or is it more likely to be like suspicious? And that's, knowing your pathology department a little bit. Suspicious for high-grade urothelial cancer or high-grade urothelial cancer. For me, both suspicious for high-grade and positive high-grade cytology raise suspicion for high-grade upper tract cancer for me. And then there's low-grade, and the last criteria is if it's cancer spreading from other sources. Couple months ago, I did a nephroureterectomy, and the patient turned out to have endometrial cancer. Just the only sign of disease was the ureteral tumor. That was very strange. So guideline statement number 4, in case of existing ureteral stricture or difficult access to the upper tract, clinicians should minimize the risk of ureteral injury by using gentle dilation technique, such as temporary stenting, pre-stenting, and limited use of aggressive dilation access techniques such as ureteral access sheets. So, big pictures here, you want to get a biopsy, you want to get a diagnosis, but not at the risk of seeding the cancer or causing, upstaging the cancer. When you have a ureteral injury, that can cause tumor seeding. And sometimes if you cannot access for a biopsy or ureteroscopic evaluation, it's just safer to leave a stent and come back another day. And in pre-stented patients, sometimes I do use ureteral access sheet because that also help bypass the bladder, reduce the risk of seeding in the bladder. But typically, I prefer to do that in a pre-stenting setting. Guideline statement number 9, at the time of identifying upper tract cancer, clinicians should perform a standardized assessment documenting clinically meaningful endoscopic findings such as multifocality, location, appearance, size, and radiographic findings such as invasions, is it invading into the renal parenchyma, obstruction, lymphadenopathy, feature to facilitate clinical staging and risk assessment. And so here is on the left is what is published in the guideline, and on the right is how I standardize my reporting. So, we don't use Epic at my institution, but we use something similar where there's like a dot face where you can just pull up, this standardized reporting, and you can make it to make sure you standardize it. So what information do you put here? And I find this also helpful for myself if I take patient back the second time, so say patient with low-grade cancer who I manage endoscopically, it's kind of like a SPARC note or CLIF note abbreviation, so I can see all the relevant information without having to read through the op report. So thing that you want to document is how did you approach the endoscopy, retrograde, antegrade, was there bladder lesions? We'll talk about how to document bladder tumor too. If there's a bladder lesion, was it biopsy? Well, the answer should be yes, right? It should be, you should remove it at the time. And then was there, where's the location of the tumor? Was there ureteral lesion? Was there renal pelvis lesions? If it's in the ureter, was it in the low, mid, upper ureter? What's the feature? What's the characteristic of the tumor like? Is it unifocal or multifocal? And then what's the size of the tumor? What some of the way that you can use to infer the size is you can use the width of the piranha forceps, or you can use the size of the flat wire basket to give you some visual reference to estimate it. It's subjective, but good to know. And whether or not the tumor was biopsy. Same thing for renal pelvis tumor. And then whether or not you send a bladder cytology, you perform a retrograde pyelogram, did you perform a cystogram? So those are just information that clinically meaningful. And then, there's also standard guidelines for reporting bladder tumor that I use. So this, if patient have a bladder tumor, I also document whether or not I do a bimanual exam. What does the bimanual exam feel like? What does the urethra look like in a male patient? What is the prostate obstructing, non-obstructing? Is there tumor in the prostate, urethral orifices? Is it in orthotopic, not in orthotopic position? How many bladder tumor, location of the tumor, size of the tumor? Those are helpful for me when I come back to the patient bladder and reassess. Characteristic of the tumor. Does that look like recurrent bladder tumor, primary bladder tumor? Was this suspicious for CIS? Clinical tumor staging. I love any type of feedback for how I assess patients, and these things are some way I go back from the pathology and see, how well did my assessment of whether or not the muscle invasion correlate with actual pathologic evaluation. Very important. Did you visually resect all of the tumor? Was there the trusor muscle present on the resection side? Was there visual suspicions of perforation? And did I leave a Foley catheter? So this is, just shout out some of the answers. So how would you describe this tumor right here? Anybody? Flat. Yeah, I think. Yeah, and what about this one? Papillary. What about this one? Yeah, and what about this one?
Maybe you can just repeat those for the people online.
Oh, okay. Sorry. So this right here, the audience was saying flat tumor. This is more papillary. Those are pretty standard. This one we say polypoid, and then this one some say papillary, some say sessile. So it's just kind of there is some subjectivity to how you describe this tumor. But again, a lot of this is when I document this report, in some way I'm I'm communicating with other people, but more like I'm communicating with myself or my future self to know what the characteristic of the tumor look like, and how aggressive the tumor looked to me. So back to our patients, I did a retrograde approach to her. So this is how I would document her operative report, and that's how I did it. Was a retrograde approach. She had bladder lesions. I did a complete TURBT, and there was ureteral lesion. To me, it was the mid upper ureter. It's a peerable, a combination of papillary and sessile. It was multifocal. There was definitely obstruction, and I did not biopsy it. I got a cytology. I think because she was low thrombocytopenia, and it looked the cytology was positive. I did not send a bladder cytology. Did not do upper tract washing. I did get a cytology. I did do a retrograde, and I did leave a ureteral stent. Now, moving on to guideline statement number 10, following standardized assessment, clinicians should risk stratify patients as low or high risk for invasive disease, T2 or greater, based on obtained endoscopic, cytologic, pathologic, and radiographic finding. And then within each of those categories, you should further classify them into favorable or unfavorable risk group. And this is what the risk stratification based on the AUA guideline. So, what determines low risk versus high risk is whether or not they have low grade or high grade cancer based on biopsy result or cytology. And then what differentiates between favorable and unfavorable risk group is the cytology. If it's high grade cancer, high grade cytology is high risk. Right, radiographic finding of whether or not they have any radiographic concern for invasion beyond the collecting system into the renal parenchyma or the periureteral tissues. Was there obstruction? Is there any suspicious nodes? Suspicious node automatically put them at high risk. If there's unifocal or multifocal tumor, if the tumor appear papillary or sessile and flat, meaning that, is there concern for CIS of the upper tract. And then, depending on what risk stratification they are in, it's going to guide what treatment is recommended, whether or not ablative therapy is an option, and whether or not they need neoadjuvant or adjuvant systemic therapy. So for my patients, it's unfavorable high-risk patient because he have high-grade cytology, he have obstruction, it was multifocal tumor, and he have a combination of papillary and flat lesions. Now, switching gears a little bit, and we're going to talk about another case. This is 64-year-old patient that is also seen for gross hematuria. So he have a CT urogram, and what you can see here is he have a high volume tumor that pretty much obstructing his urinary flow. And then what you see right here is a big paracaval lymph node. So just a show of hand, how many people would biopsy just the left renal pelvic tumor alone? Okay. How many people would just send him to IR for biopsy of para-aortic lymph node alone? And how many would do both? Okay. So what I did is, I did a cystoscopy to make sure that he had no bladder tumor, and then I also sent him to IR for a CT-guided biopsy of the para-aortic lymph node. And it came back metastatic high-grade urothelial cancer. I did not look in his upper tract because, it's the clear tumor, and to me, if the biopsy of the lymph node was positive, we pretty much know what he had. I staged him, and then he ended up undergoing a neoadjuvant chemotherapy, and I subsequently did a nephroureterectomy and rectoperitoneal lymph node dissection. And switching gear a little bit, we're going to talk about some family history here for patients with suspected upper tract cancer or diagnosed upper tract cancer. Clinicians should obtain a personal or family history to identify known hereditary risk factor for familial diseases. And this here being Lynch syndrome, right? So, and refer them for genetic counseling. So Lynch syndrome is used to call HNPCC, or hereditary non-polyposis colorectal cancer syndrome. That's the old term, because now we know that it's not just colorectal cancer. It's a pain cancer syndrome. It's the colorectal, endometrial, upper tract ovarian cancer. And while most syndromes are moving away from, the individual name, this one is one of the few. It's one of the few cancer that moving toward an individual name. Lynch syndrome is autosomal dominant disease. That means if you have the mutations, you will develop cancer. There are highly likelihoods, and almost all patients with Lynch syndrome have a family history. It's rarely de novo, unlike VHL, where 10 to 20% of patients may be the first one in their family to have VHL syndrome. In Lynch syndrome, you almost always have a family history if you look for it. It's caused by germline mutation in DNA mismatch repair genes. So far, we know of 5 genes implicated in Lynch syndrome, which is MSS2, MSS6, PMS2, MLH1, and EpCAM. EpCAM typically occur with MSS2, rarely alone. And the hallmark of Lynch syndrome is colorectal and endometrial cancer. We talk about, that's why if you see a urothelial cancer patient, the question should not be, do you have any family history of urologic cancer? It's whether or not you have family history of any cancer at all, especially colorectal and endometrial cancer. And despite being a rare cancer, upper tract cancer is the third most common Lynch syndrome associated cancer. The cited in literature that about 5% of patients with Lynch syndrome have with upper tract cancer have Lynch syndrome, but that's typically is probably an underestimate. And the tumor phenotype of Lynch syndrome is mismatch repair deficient or MSI microsatellite instability high. This is the data based on the NCCN guideline to see how you should counsel patients about their risk of Lynch syndrome. In the interest of time, what I just really want you to take from this slide is that MSS2 mutation have the highest risk of upper tract cancer compared to patients with, say, PMS2 mutation. And how do you screen for Lynch syndrome? Again, family history, colorectal and uterine cancer, especially early age of onset, or a patient who saw you with upper tract cancer who also have a history of colorectal endometrial cancer. But really, the tumor testing is what's really going to help you capture the majority of patients with Lynch syndrome. As you can see here, if you screen patients based on tumor testing for microsatellite instability, IHC, you're going to capture the majority of them. And again, that guideline recommended universal tumor testing, which can be done. So that's wrap up the first part of my talk. Thank you.
So in the interest of time, we're going to move on a little bit quickly to the next talk. I think emphasizing that last point, though, that Dr. Truong mentioned is very, very important. That is that the guidelines recommend that all patients with upper tract cancer, regardless of age, should have MSH testing or should have MMR testing through immunohistochemistry. So at your centers, wherever you are, if you have a patient with upper tract cancer and the pathology goes to the pathology department and it comes back and they have not done immunohistochemistry to look at MMR genes, again, it's not a genetic test. It is a test to look at expression of those genes in the tissues. So it's not genetic testing. It should be done as a reflex test in all patients. If they haven't done it, you need to call your pathologist and say, this is now recommended as guideline directed care. It's a billable test. They do it. They give you the answer back. If it's positive, then you send and you refer for genetic testing. So that's a very important point you need to get across, and that is all patients have to have it done. Sorry, what?
Are you able to go to the mic? It's just live broadcast. If you could just go to the mic, just so it catches it. Thank you.
Have you discussed to document it with a video or with a picture, or is it just description of the tumor that has been discussed as a standard?
Yeah, so great question. For bladder cancer, there is now a standard, reporting process for bladder cancer for TUR, what you see in the time of cystoscopy and TUR. For GI, they have a standard program for doing that as well, which includes imaging. We can't mandate that, but it is recommended that imaging should be taken whenever possible if you have that capability.
Okay, thank you.
Hello, I have one question regarding the mismatch repair mutations. Let's see the other way around. Let's see, the colorectal refers to a patient who had a colorectal cancer and it was identified with these mutations. Is there any specific recommendation to work up these patients, only urinalysis or imaging?
Yeah, so what you're referring to is in patient with a diagnosis of Lynch syndrome, but have not developed urothelial cancer. How do you screen those patients for bladder cancer, right? So the current the current NCCN guideline does not recommend routine screening for urothelial cancer for patients with Lynch syndrome because the data is very poor. But in patients with high risk of developing urothelial cancer, such as those patients with MSS2 or MSS6 mutation, so it's important to know not just patients have Lynch syndrome, but specifically what genes do they have the mutation in, right? Or if they have family history of urothelial cancer and Lynch syndrome, then it's reasonable to start screening them at around, at least for me, 30 to 35 years old. And I typically start with a urine analysis with microscopy. If they have a positive microscopic hematuria, which is 3 red blood cell or more, I work them up according to the the hematuria guideline. They're not low-risk patients regardless of whether they smoke, right, because they have a genetic predispositions. And so, if they haven't had any cross-sectional imaging, I guess CT urogram and go from there.
I have a question about the immunochemistry. I was wondering whether it is necessary a big amount of tissue to acquire during biopsy to perform the immunohistochemistry, or just the same sample with which we acquire the diagnosis of cancer.
Yeah, briefly, sample size can be an issue, but usually they can do it even on small samples. Yeah.
Great. So what I'll do is I'm going to build off of what Hong spoke about with regards to sort of diagnosis, initial evaluation, and we're going to talk about management. And the first element of this is what I think has really blossomed over the last 5 to 7 years, and I think what will continue to blossom, which is really concepts of kidney management, kidney sparing management, and how that factors into the algorithm. These are my disclosures. I am a study site investigator for a number of different clinical trials, some of which pertain to upper tract urothelial cancer, and I was a member of the guidelines panel. I do want to acknowledge a few friends and colleagues who have shared some videos that I'll be showing you. I think it's always helpful for urologists and surgeons to see videos and pictures, and obviously sometimes those videos and pictures are not always your own, and these are friends who are kind enough to share with me. So I think what's the scope of the problem? I think the scope of the problem is that if you look at population-based data, and this is data from the National Cancer Database, the NCDB, the reality is that when you look at patients diagnosed with low-grade upper tract urothelial cancer, a relatively small number of them are actually managed by endoscopic management or kidney preservation. Now, I'm not going to tell you that every low-grade tumor should be managed by kidney preservation, but I would tell you that there's probably more of an opportunity than 1 in 5 cases. So I'm going to give you 4 basic rationales of why kidney preservation makes sense. Number 1 is, if you look at the nephroureterectomy literature, the reality is this is an operation that does have potential associated side effects and complications. This multi-center study looked at over 700 patients, identified a close to 40% complication rate, of which 8% of these were major complications. Secondly, as is going to be shown, radical nephroureterectomy can worsen CKD, and patients with upper tract urothelial carcinoma at a baseline have more or higher degrees of CKD than the general population. The third is that if you look at some theoretical cost models and you look at patients with a solitary kidney who had a nephro-U versus a solitary kidney with kidney preservation and assume that they recurred over and over again, that was still less costly than a nephroureterectomy followed by hemodialysis when you look at a 5-year cost estimate. And finally, although the data is far from perfect, if you look at comparator series, and again, these are not prospective, they're not randomized, they're retrospective, maybe case control, but you see that observational studies show that kidney sparing approaches, endoscopic management does indeed have similar cancer-specific survival and improved renal function outcomes compared to nephroureterectomy. I think the crux of all of this is that patient selection is critical and is key, and the appropriate patient selection is really predicated on that risk stratification system that Hong showed. So I think a few of the key points. Number one, when you look at the low-risk favorable cohort, tumor ablation, and I'll go into detail a little bit more about what is tumor ablation. That's really endoscopic ablation and also now in the past few years, chemoablation. But tumor ablation overall should be the initial management strategy for low-grade favorable upper tract urothelial cancer. I've highlighted the low-grade and low-risk features, and then in green is really what we're talking about with the favorable cohort. And that's really solitary tumors, low-grade tumors, no evidence of radiographic invasion, unifocal in nature. It's important to recognize that there are other opportunities to use kidney preservation. So it's not only restricted to that cohort. The guidelines do talk about using this strategy in patients with low-risk unfavorable disease and some select high-risk favorable disease cohort. So that's going to be the middle two boxes here. Low-risk unfavorable might be multifocal tumors, albeit being low-grade. And there are some select high-grade tumors where at least I think it needs to be part of the discussion. Every case, absolutely not. But maybe what, a 1 centimeter high-grade tumor, is it reasonable to have that discussion? It very well may be based upon the patient comorbidities and other factors. So I think just looking at this, we were speaking earlier today, and Jonathan and I were talking, and he made a very good point, which is, the far left-hand side for you all, which is the low-grade favorable, really that's the wheelhouse for kidney preservation. The far right-hand side, which is high-grade or high-risk unfavorable, obviously we're really thinking about extirpation. But I think in that middle area, there's a gray zone. And the gray zone, I think, is at the discretion of you as clinicians and surgeons, and obviously patient preference. So let's look at a few cases here. 63-year-old male, former smoker, has gross hematuria with a 25-pack-year smoking history, good performance status, normal renal function. If we follow the standard gross hematuria evaluation of these patients, the patient should have 3 things: axial upper tract imaging, in this case CT urography, a cystoscopy, as well as a urinary cytology because of gross hematuria. The cystoscopy was negative. The cytology was negative. The CT urogram shows a 1.5 centimeter filling defect in the lower pole of the left kidney. This is a representative picture of a retrograde pyelogram showing this lesion. Biopsy of that was low grade. And so you can see that it fits into this bucket over here, which is just a favorable management or favorable upper tract. So what are the management strategies? Endoscopic tumor ablation or chemoablation, I'm going to talk about each of these. If we look at endoscopic tumor ablation, we're really looking at ureteroscopic or percutaneous approaches and delivering some type of energy to ablate or kill the tumor. There is really no consensus in the literature on what exactly to use. There's variations in lasers, and there's some positives and negatives of using different types of lasers. Some hospitals only have electrocautery with thermal energy via something like the Bugbee. That's also quite reasonable. I think you just use the tools that you have at your hospital. But the key thing is that settings may vary throughout the case. I think in urology, our wheelhouse lasers that we use most commonly for upper tract are going to be the holmium laser and the thulium laser. And I've put in some of the key characteristics of them, both the wavelengths that they work at, but then maybe the key distinguishing feature between them is the holmium laser is a pulse laser, the thulium laser is a continuous laser. If we look at some of the specifics for the holmium laser, the key thing is that really the tip of the laser needs to be in contact with the tumor tissue. There are different settings that can be used, 0.5 to 1 joule, different frequency that can be used, 5 to 30 hertz. So to sort of illustrate what I would call the short pulse mode is about 0.5 to 0.6 joules at 5 to 10 hertz. What you see is a very slow treatment effect, but very good visualization. And as you work through, you can sort of get a sense of what kind of progress are you making with this. It's a very good and easy and safe way to start, especially if you're thinking about the possibility of a more vascular tumor. But if you're just not making progress, you can go to what I call the long pulse mode. So the long pulse mode is, let me see if we can advance it. There we go. The long pulse mode, 1 joule and 30 hertz. You can see that it's much more effective in ablating the tumor at an expense of visualization. You can see that you don't see nearly as well. It's more of a sort of a snow globe effect. And I think the key thing is you need to be able to go back and forth because visualization is absolutely critical during these procedures. Now, what happens at the end of the procedure? You get down to the base of the tumor and you're getting some bleeding. And you really want a little bit more energy to go deeper into the tissue to coagulate. A lot of our lasers that are holmium actually have a holmium neodymium, sort of toggle on them. The neodymium has much greater depth of penetration, very good for coagulation in the kidney and the renal pelvis, not so good in the ureter just due to through transmission and risk of stricture. If we go to the thulium laser, again, this is a continuous laser. It's much more of a smooth cut. The power and the frequency settings, I think, are a little bit more set in stone. It's about 1 joule of power, 2 hertz of frequency. And you can see here, this is from Mantu Gupta. He shared a very nice video of a thulium laser for a ureteral tumor. And you can see that the one notable difference is you don't quite have as much of that snow globe effect that you're seeing. But you will see that there is even the potential of getting fairly deep into the tissue. And I think there are pros and cons. There's no perfect laser out there. I think some folks really like the thulium laser because of this continuous effect. Some like the holmium laser. There is a risk of charring at the base for the thulium laser. So again, this is a ureteral case. You have to be careful with that. I've showed you some pretty pictures. The reality is it's not always pretty. So this is a case where patients had a ureteroscopic biopsy. It's bleeding. And even before you can get to ablating the tumor, you're just trying to survive and see for the first portion of this case. And so I think a lot of that is part of reality, which is you're getting your laser, trying to get coagulation to actually see what is going on before you go through the procedure. And so I would be remiss if I didn't show you videos like this, because this is part of the reality when you try to manage upper tract endoscopically. I am a believer that an access sheath is very helpful in these cases. I think this is true for stone disease, but especially if you think about lasering tumor and you have a high pressure system within the kidney. I always worry about pylolymphatic and pylovenous backflow, and there's clear data that shows an access sheath may be beneficial. There's also data that suggests that an access sheath may reduce your likelihood of downstream seeding into the bladder, as well as ipsilateral recurrences. So I think there's two compelling factors. Again, do you have to? No, but I think there's some data that says it may be of benefit. I do think we should think about putting some type of drug or therapy into the upper urinary tract or into the bladder after treatment. I think the data is imperfect, but I think there's at least enough compelling data, and you can extrapolate from the bladder cancer literature that there may be some benefit. This is a recently published paper by Zhu and colleagues that looked at installation of BCG and mitomycin into the upper tract. You can see that the response rates or the recurrence rates is about 30% for BCG, 40% for mitomycin. What's the classic problem with putting drug into the upper tract? Well, it's gravity. It's an aqueous solution in general. It's dripped down from the upper tract. How do you get dwell time? How do you get contact surface? I do think that we also don't know the perfect drug, the number of installations, and the amount of dwell time. One of the studies that I think is pretty good is this study from Mantu Gupta that looked at different delivery mechanisms of drug into the upper urinary tract. And this paper really did find that retrograde installation via a 5 French ureteral catheter, when you just look at methylene blue, did seem to have the best coverage of the upper urinary tract when compared to percutaneous installation or a ureteral stent with retrograde flow from the bladder via reflux. I also think that there's a real likelihood with ureteroscopic manipulation of upper tract tumors that there is downstream seeding. If you look at the nephroureterectomy literature, those patients that went to nephro-U versus those that had a ureteroscopy and then nephro-U, the ureteroscopy group had about a 1.5-fold higher risk of developing a subsequent bladder tumor. I think that's probably due to manipulation. And that occurs whether or not you're biopsying and ablating the tumors or simply just looking up, seeing the tumor, and then proceeding on. I think that positive pressure and the manipulation. So I think we have to recognize that downstream seeding occurs. I think one of my practices is for any ureteroscopic management of an upper tract tumor, I do put intravesical gemcitabine. I use 2 grams in 100 cc's of normal saline post-ureteroscopy. This is a may, meaning this is not should, it's a may. It's one of the guideline statements where it's extrapolative data. I think it's compelling, but I think it's certainly not no level 1 data that says you certainly must do this. Remember that tumor ablation can be done via an antegrade or a retrograde approach, but the most important principle is you need to look back and endoscopically visualize the area of resection within 3 months. This is excellent data from Olivier Traxler, who's probably one of the best endourologists in the world, that basically showed that after endoscopic ablation, 50% of patients still had a tumor in the upper tract at 8 weeks. The vast majority were in the same place as the primary tumor. So we don't do as good a job as we think we're doing. Now, I talked about tumor ablation. We've talked about endoscopic tumor ablation. There's also chemoablation. And really right now, the drug that's on the market for chemoablation is Jelmyto or UGN-101. The whole idea here is mitomycin that is complexed or embedded in RT gel, and this contours to the surface of the inner urothelial lining of the kidney, and therefore potentially increases dwell time and increases concentration. This is the Lancet Oncology paper from a few years ago that showed the value of UGN-101 in an ablative setting. So this is not adjuvant. You don't give this, according to the study, after you've done ureteroscopy. It's to ablate a tumor in place. What do I think is the wheelhouse for this type of therapy? I think that potentially multifocal tumors, which is a good number of the patients in the study, and tumors that are unreachable by ureteroscopy, of which in this study almost 50% were unreachable, meaning it's hard to endoscopically ablate them. Success rate, not perfect, good but not perfect. 59% response rate, and we have to recognize that even for those responders, 80% were durable at 12 months. And we cannot minimize the potential risk associated with this therapy, and the most notable was ureteral stricture disease, which occurred at various degrees, but anywhere from 17% mild all the way up to 7% moderate to severe. So let me present to you a second case. This is sort of the opposite end of the spectrum. 83-year-old male, right upper tract disease, previously had a nephro-U, so he's a solitary kidney, had cystoprostatectomy with bladder cancer, so now has an ileal conduit. Now has intermittent gross hematuria. The evaluation of this involves laboratory testing, which shows the patient has CKD stage 4 with a GFR of 22, good functional status. Had a non-contrast imaging study showing a filling defect in the left kidney, or at least a soft tissue density, in the left kidney, with retrograde pylography via the conduit showing a filling defect, and biopsy showing a high-grade lesion. So this is a tough situation. Solitary kidney, high-grade lesion, GFR of 22, 83-year-old male. Staging evaluation was negative. The patient refused dialysis. We had a multidisciplinary tumor board, and really the discussion was the patient's bleeding. There's no evidence of metastatic disease. So these are those indications which are imperfect, but you really do think about possibly using ablative therapies even in some of these higher risk, higher grade scenarios, more for an imperative indication in certain patients. What's that? Including the...
One of the questions came up.
Oh,
Chemoablation for
Yeah, sorry. One of the questions that came up from our online was the concept of chemoablation and can you use it in the ureter? So the initial trial I just showed you, that was for the renal pelvis. There is actually now subsequent data that has been shown that it can be used within the ureter. So actually the broad FDA indication for chemoablation is any component of the upper urinary tract, kidneys, as well as any component of the ureter down to the bladder. So getting back to this case that I just mentioned, so these are some of the cases where you can use endoscopic ablation, albeit in a higher grade and higher risk patient. You can do it via an antegrade percutaneous approach, but if you are treating high-grade tumors, I really think you need to give some sort of drug into the upper urinary tract, most likely BCG, and that should really be for high-grade tumors or those with any type of concomitant CIS. Correct. And sort of the principle there being you can't use BCG in lieu of complete ablation or complete resection. And that's very similar to what we see in the bladder cancer literature, right? You have to resect the tumor and then you can give drug. The drug is not going to take the effect, especially for BCG, than resection. I'll finish by saying you have to counsel your patients for endoscopic management and kidney preservation, that they are going to probably recur. And here are the broad recurrence rates. About 65% will recur in the upper tract. About 40 to 50% will recur in the bladder. The follow-up is largely predicated on risk stratification and whether you preserve their kidney or not. But here are some of the key take-home messages that I would tell you with regards to kidney preserving strategies. First of all, the follow-up algorithm that most of us have outlined in the guidelines is 5 years. The second is if you look at kidney preserving protocols, endoscopic evaluation of the upper tract, meaning ureteroscopy most commonly, is only really required or recommended strongly for the first 12 months. Thereafter, you can rely on CT imaging or MR imaging, cytology, and cystoscopy as means of following the upper tract without having to repeatedly instrument the upper tract, provided the patient has no evidence of disease recurrence. And finally, I would say you can't be dogmatic about this. So some patients are going to progress, they're going to have worse grade, they're going to have a higher stage, their tumor's going to become bulky. And the most important thing is not to persist with endoscopic or kidney preservation when it's clear that that strategy is not working. You have to pivot to some type of extirpative surgery, whether that's nephroureterectomy or a segmental resection. So to conclude, think about using endoscopic strategies, think about kidney preservations, particularly for low-grade tumors. There's no perfect recipe. Use the tools that you have in your hospital, whatever they might be, with regard to ureteroscopic, percutaneous, lasers, or even electrocautery. Counsel your patients that recurrences will occur, and that's part of the whole decision-making algorithm. And follow and adhere to the surveillance regimens, because that'll make sure that you don't miss disease that has progressed. Thank you.
We've got time for a couple of questions, if anyone has any. Please use the mic.
Yes, are we warranted to use chemotherapy or chemoablation or the gemcitabine, BCG, if we don't have adequate tissue biopsy? Like a lot of times what we struggle with is we go in and there are numerous small tumors that if we biopsy, the pathology would say not enough tissue. Are we, I mean, we can laser, of course, but are we warranted to use chemoablation or BCG or mitomycin in that setting?
So I think the question is really intracavitary therapy without having biopsy-defined disease. And I think that, I have a few broad thoughts on it. I think, first of all, what you're saying is a reality. Sometimes the tumor tissue is small, and so we are limited by our ability. I have some great concerns about using, chemoablation. If you just take Jelmyto, for example, that's really approved for low-grade disease. And so I have a lot of concerns on using that drug without clear evidence that you have low-grade disease. And I think if you at least looked at the trial, some of the failures were because it was high-grade disease, and we didn't have an adequate enough sampling, I believe, to know that it was high-grade disease. I do think that low-grade or high-grade, there is almost without a doubt when you do endoscopic management of these tumors that you're seeding. I think there is. And so I am a believer that putting some type of therapy at the time that you're doing the procedure, whether that's in the bladder or even some in the upper tract, I think there's some value in that. I'm not sure that BCG is the right answer, obviously, in the acute setting. So I typically use gemcitabine just because it costs less and it's a little bit less caustic than mitomycin. But I don't think there's a right or wrong answer of which drug you specifically put.
Just to follow up on the gemcitabine, are you keen to getting the gemcitabine to the upper tract or just in the bladder?
So I kind of believe in the drip down. So I believe if I put it in the upper tract, it's eventually going to make it down to the bladder. So I try to put it, if I can, in the upper tract. If I'm at all worried about high pressure, if it looks ratty at the end, any concerns at all about perforation, I would not put it in the upper tract. I would just put it in the bladder at that point.
Thank you for the presentation. So, two questions. One about ureteroscopy and nephews, and because you showed that the slide clearly shows high risk. So, do you perform ureteroscopy before the nephew to confirm it, i.e. on the same setup, or do you do it as two separate? And do you think it makes a difference? Because the patient is going to have two surgeries instead of one. That's one. The other thing is about intrarenal chemotherapy that you mentioned. So you think by putting some, let's say even mitomycin, and just putting a stent, that's enough just to wash and then come down through the stent, and it does help? Thank you.
So the two questions are ureteroscopy, of which you're right. I think there's a lot of data that does show that if you look at the nephroureterectomy literature, those that have had a prior ureteroscopy do have higher bladder cancer recurrence rates. If you look at the whole risk stratification algorithm for upper tract, though, a lot of the risk stratification algorithm is predicated in part on biopsy data, right? So I think you have to do them in two different settings if possible. Is it possible at every time? No, but I think if you're trying to say, is this a low-risk person, is a high-risk person, and that's based on biopsy grade, I really do think you have to ureteroscopically evaluate them. You need to biopsy them, map out their focality, and then really have a discussion about with the patient, are you low risk or high risk, and then what falls into the algorithm. So I'm a believer of two different as opposed to the same setting. I think that with regards to installation of drug, I think the most compelling, I think, is that I do believe it will decrease your likelihood of bladder tumor recurrence. I'm not sure giving drug aqueous in the upper tract, I think it's questionable how much it decreases your upper tract recurrence rate, but the way I think about it is, at a minimum, I'm going to get some bladder benefit out of it, and so I think that's the idea.
Did you consider the genetic mutation to perform a endoscopic treatment, or like if he has a Lynch syndrome, would you do the endoscopic treatment?
So I'll let my, to me, if that person has Lynch syndrome, which is going to predispose them to multifocality and recurrence, yes, I mean, I'm thinking very much right out of the gate, very similar to kidney cancer and the VHL patients, you're thinking about preservation as much as possible because the natural history of the disease is recurrence. So I do. I think more about it, and maybe you start swinging out of that lowest risk cohort and entertaining sort of that intermediate grounds for endoscopic ablation in those that have a hereditary mutation, but would sort of defer to my colleagues on their thoughts.
No, I have nothing I'd add. I'd say that, I think organ sparing in that scenario is very important because they're also, we always quote this rate of a patient with upper tract urothelial carcinoma is at 5%. Everyone always asks, well, what about my other kidney? Which sometimes prompts some people to, do an endoscopic procedure on the opposite kidney just to check, which the guidelines very clearly state you should not do unless there's some compelling reason to do it because there's huge risk of injury or seeding and other things that can happen. But that 5% risk that we all cite may actually be in patients who up until now we didn't realize actually had Lynch syndrome, and now they're at higher risk for contralateral disease. So I think organ sparing is even more imperative in patients with Lynch syndrome.
Thanks.
So I think with that we'll have Nicholas will come and talk to us a little bit more about multidisciplinary care. So we're pleased to have Nicholas Simon come from the NIH to provide this portion of the talk.
All right. Hi, everyone. My name is Nick Simon. I'm a medical oncologist at the NCI. And just so I get a lay of the land, how many out there are more on the medical oncology side of things? Raise your hand. How many are on the urology side of things? Okay, perfect. So for my talk, I'll be talking about some of the considerations in the perioperative space, kind of what I'm thinking about as I'm moving into a tumor board, some of the questions that I want to ask. And then I'll go through the kind of three big buckets of treatment modalities we have: neoadjuvant chemotherapy, adjuvant chemotherapy, adjuvant immunotherapy, where there's been a lot of new data recently, and then end with some trials in progress. To center our discussion, I'll use a case. This will be the kind of same basic case, and I'll just change a few of the details as we go through. So for case number one, you have a 63-year-old male who came to his PCP with 2 months of hematuria and flank pain. He got CT imaging. It shows this ill-defined lesion in the right upper pole. He got a biopsy that showed high-grade UC. Past medical history is unremarkable. His creatinine is 1.3 with a clearance of 63. So, what are the options that we're thinking about for this high-risk upper tract patient with good renal function? Are we thinking more neoadjuvant therapy, adjuvant chemotherapy, or adjuvant immunotherapy? And for me, a lot of what I'm thinking about is, what is this patient's cisplatin eligibility? And we have a criteria called the Galsky criteria that helps us delineate who's fit and unfit for cisplatin. So I think of patients being unfit for cisplatin if they have an ECOG of 2 or greater, hearing loss or neuropathy grade 2 or greater, NYHA heart failure greater than grade 3, or, and kind of most importantly for these patients, what their kidney function is, a creatinine clearance of less than 60. In practice, you'll see that kind of go down to 50 or 55, particularly if we split dose the cisplatin, but usually thinking about a renal function around kind of 55 is the cutoff. And why am I thinking about cisplatin eligibility? Well, because the cisplatin eligibility really changes depending upon when we treat the patient. So this is a really great figure that Dr. Hoffman-Sensis created, showing that about 60% of our patients are going to be cisplatin eligible, but that number drops significantly down to 15% after they get surgery. So you really have this window of opportunity in which we can use cisplatin. And why is that? Why is there so much focus on cisplatin? Well, we know in urothelial cancer that cisplatin just performs better than carboplatin. It's more efficacious, particularly in the metastatic setting. So that's what we're kind of extrapolating from. So what does the AUA guidelines say about recommendations for neoadjuvant chemotherapy? Well, they say clinicians should offer cisplatin-based neoadjuvant chemotherapy for patients undergoing surgery, particularly in those patients whose post-operative GFR is expected to be less than 60. So again, thinking about your patient, thinking about how fit they are and what surgery may do to their kidney function. Where does this data come from? Where there have been 2 phase 2 trials. Most recently, Dr. Coleman and his colleagues published this paper in JCO in 2023. And it was a multi-center, single-arm phase 2 trial of upper tract patients. And so in order to be eligible, you either had to have a high-grade biopsy or you had to have suspicious imaging paired with cytology. Here the GFR cutoff was 55, and what they were looking at was really pathologic response. How many of these patients were being downstaged, with secondary endpoints being pathologic complete response, PFS, and OS. And they gave these patients split-dose gemcitabine. So one of the interesting things about this paper is that you have this kind of prospective cohort of patients, and you really get to see what happened to their kidney function pre- and post-operatively. So you can see the median GFR was 72 at baseline, 70 after getting the neoadjuvant chemotherapy, and then dropping down to 40 1 week after. And we don't really see a kind of return to baseline after surgery. It remains in the mid-40s. And so again, you can see we may have missed a window of opportunity for treating patients with cisplatin if we wait to the adjuvant setting. So what were the outcomes of the study? Well, they saw 63% of patients were downstaged, had less than YPT2 disease, and about 20% of patients had complete pathologic responses. Looking at the 5-year outcomes, 72% had progression-free survival, whereas about 80% of patients had 5-year OS. To kind of put this in context, Down in the bottom left, you can see for the POUT trial, the 5-year DFS was 63% and the 5-year OS was 65%. Again, there are a lot of caveats with cross-trial comparisons, but just to kind of give you some of the ballpark numbers that we're talking about. And how did this compare to the other study that was done in this space? So the other study was the ECOG Akron study, a slightly smaller study, about 29 patients, but you can see very similar outcomes. So about 62% of patients had downstaging, 14% of patients had pathologic complete responses. So it looks like giving neoadjuvant chemotherapy does lead to downstaging, and in a certain percentage of patients does lead to complete pathologic responses. So does that matter? Well, if you look at the outcomes stratified based upon their pathologic response, it really clearly does. You can see, here we go. You can see these green lines are patients who had complete responses, 100% PFS and OS. For those with partial responses, 86% PFS, 90% OS. And then for those who were not responding, about 50% of them would progress, and about 58% of them were alive at 5 years. So in summary, when we're thinking about neoadjuvant therapy, about 63, about 2/3 of your patients are going to have pathologic responses. About 1/5 of them are going to have pathologic complete responses. And you do see this significant decrease in their renal function. One of the major caveats when we're talking about neoadjuvant therapy is just how difficult this disease is to stage. So really, is the pathologic response that we're seeing just overstaging because we didn't have a great imaging, or it's hard to get a biopsy, or the cytology was misleading? And so we kind of have to have that caveat in our mind. So going back to our case, again, same 63-year-old gentleman, same lesion in his kidney. This time, creatinine function is not as good. Creatinine's 2, creatinine clearance is 45. Patient does not receive neoadjuvant chemotherapy, and they underwent a nephro-U. This time, their disease came back with PT3 disease. So not a cisplatin candidate. So what does the AUA talk about in this situation? Well, when thinking about adjuvant chemotherapy, clinicians should offer platinum-based adjuvant chemotherapy, and this is a strong recommendation based upon grade A evidence. And that evidence comes from the POUT trial. So this was a phase 3 trial, randomized open label. You had to have upper tract disease, PT2 to PT4 and 0 to 3, or PT any and be node positive. And they randomized these patients 1-to-1 to receive either chemotherapy or to be on surveillance. When talking about the chemotherapy, the patients could have received cisplatin or carboplatin. Again, there's a lot of nuances when you're thinking about whether someone's cisplatin eligible or not. And so in this trial setting, they had pretty strict criteria based only upon renal function. So the only reason you could get carboplatin was if you had decreased renal function. And here, they're looking at the primary endpoint of DFS and then also OS and toxicity. One of the major caveats to know about this trial is that it was closed early due to efficacy. So it didn't fully accrue, it only accrued about 3/4. And we'll come back to that as we talk through some of the results. So the 5-year results were just recently published in the last month or two, and it shows that the 5-year disease-free benefit was 62% in those receiving chemotherapy, 45% in those on surveillance, with a hazard ratio of 0.55. So very clearly improved DFS with chemotherapy. Looking at overall survival, the 5-year OS for those receiving chemotherapy was 66% compared to 57%, those with surveillance. Hazard ratio of 0.68. Technically, those confidence intervals included 1. So a very strong trend towards significance. And again, with the caveat that this trial was closed early due to efficacy. And again, putting those numbers from the neoadjuvant trial in there just so that we kind of have the context of what these DFS and OS benefits are. Drilling down a little bit more into the subgroup, we talked about the cisplatin and the carboplatin, and if you focused on what the planned chemotherapy was, you can see it does seem like the patients who are receiving cisplatin derived more benefit than those who received carboplatin. And it was about, 65-ish% of the patients who received cisplatin compared to carboplatin. But again, those patients seem to be doing better. So what's the takeaway from the POUT trial, which is the adjuvant chemotherapy space? Well, there's a significant DFS benefit with 45% lower risk of recurrence or death. There's a trend to OS benefit, though the trial was stopped early due to efficacy. And about 75% of chemotherapy patients were able to receive all 4 cycles. And again, as you know, it's really hard to give chemotherapy in the post-operative setting. So having 3/4 of patients receive the therapy is pretty good. One of the caveats of this trial, again, is that almost half of the patients received carboplatin, and about 20% of those who were planned for cisplatin were not able to receive all their doses of cisplatin and had to be switched to carboplatin. So moving on to our final case, again, same 63-year-old gentleman, same right upper pole lesion. This time their creatinine clearance was 84. They did receive neoadjuvant chemotherapy. Unfortunately, on their path after nephro-U, they had persistent YPT2 disease. So what's the recommendation about adjuvant immunotherapy? It says adjuvant nivolumab may be offered to patients who receive neoadjuvant platinum-based chemotherapy or who are ineligible for or refuse perioperative cisplatin. And this is a conditional recommendation based upon grade B evidence. One of the major caveats to know as we go through the next 3 immunotherapy trials is that these trials included lower and upper tract patients. So keep in mind, and we'll talk about the percentage of upper tract patients included, but these are all urothelial cancer patients. So the first one and the main one that the AUA guidelines reference is this CheckMate 274. So this was with adjuvant nivolumab. Again, you had to have YPT2 to 4A or node-positive disease if you had received neoadjuvant chemotherapy. And for those who did not receive neoadjuvant chemotherapy, you had to have PT3 to PT4 or node-positive disease. These patients were randomized 1-to-1 to get nivolumab or placebo for 1 year. And the primary endpoints were disease-free survival in the intention to treat and PD-L1 positive group. And for this trial, the upper tract patients were capped at 20%. So this was a positive trial. You can see for the DFS and the intention to treat group, the 12-month DFS was 62% versus 46% for those treated with placebo. That's a hazard ratio of 0.7. In the intention to, or in the PD-L1 positive group, that benefit was even higher, this time with a hazard ratio of 0.55. But what about our upper tract patients? Did they receive this same amount of benefit? And if you look at the subgroup analysis, you can see that for the renal, pelvis, and ureter patients, they didn't seem to derive as much benefit. Similarly, when you're thinking about the patients who received neoadjuvant cisplatin, those who did not receive as much benefit, and those who had worse creatinine clearances of less than 60 also did not seem to derive as much benefit. And there's probably a lot of overlap between our upper tract patients, those who did not receive neoadjuvant therapy, and those with worse creatinine clearances. One of the really exciting things that happened in the last month was that at EAU, we had the first presentation of the OS data. The caveat with this data is that at the time of presentation, it had not reached the pre-specified statistical landmark for analysis. So we can't say anything about how statistically significant this is, but looking at the lines, you can see that there does seem to be a nice separation in both the intention to treat and even greater in the PD-L1 positive group. So it does seem like this is trending in the right direction, and that in addition to DFS, we may also be seeing an OS benefit for these patients. In addition to the OS benefit, they also presented the subgroup analysis. Here you can see kind of confusing results. There seems to be maybe some benefit in the renal pelvis patients, no benefit with the ureter patients with the adjuvant nivolumab. You know, what's going on? I think the numbers are too small to really derive any definitive explanations about this, but this is the data that we have. Briefly going into the next two trials, so there's the Ambassador trial, which was adjuvant pembrolizumab. Again, this was very similar to the nivolumab trial. This time, the one caveat is that as opposed to placebo, patients were randomized to observation. And here, there was no cap on upper tract patients, and it was about a quarter of the patients who were enrolled. Looking at the primary endpoint of DFS and OS, for the DFS, there was a significant benefit. The median disease-free survival was 29 months with pembrolizumab, about half that 14 months with observation, a hazard ratio of 0.69. For OS, you're not seeing the same results. The hazard ratio is 0.98, and there's no significant difference in median OS. One of the major caveats about the Ambassador trial is that the Ambassador trial was ongoing when Checkmate 274 resulted and nivolumab got FDA approval in the adjuvant space. So there is differential censoring on the observation arm compared to the treatment arm. So I think a lot of people were dropping out and going to get off trial nivolumab, and so that's probably contaminating the results that we're seeing. What about upper tract patients? Again, looking at the subgroup analysis, we're not really seeing that our upper tract patients are deriving the same amount of benefit as the bladder cancer patients with this treatment of adjuvant pembrolizumab. And the last trial I'll touch on is the IMvigor010. Again, very similar trial, this time adjuvant atezolizumab. Patients were randomized to receive that or on observation. This time, they capped the upper tract patients at 10%. This was a negative trial. The hazard ratio was 0.89. And again, looking at our upper tract patients, it did not seem like these upper tract patients were really deriving as much benefit from adjuvant immunotherapy. One of the interesting analyses that came out of the IMvigor010 was looking at ctDNA and using that as a way to potentially risk stratify our patients to see who will derive the most benefit from treatment. So briefly going through these charts, you can see that these upper lines for DFS and OS show that there's no difference in patients who are ctDNA negative who either got atezolizumab or observation. There's no difference in DFS or OS. When you look down to these bolder lines here, these are ctDNA positive patients, and you do see an effect of therapy. So you see that the patients who are receiving atezolizumab have improved DFS and OS compared to observation. So in the future, this may help us further identify patients who would most benefit from further treatment.
Just to clarify that statement a little bit, so can you explain what you mean by ctDNA positivity, after surgery?
Yes. Yeah, so this was post-operative single analysis of looking at patients who, after surgery, had ctDNA testing done and were found to have detectable ctDNA that was circulating. And that was done with a bespoke panel. Similar analysis was also done with one of the commercial preset panels with very similar results.
So that would indicate that patients probably have some type of micrometastatic disease that's still in their body after nephrectomy, whereas those that were ctDNA negative, likely didn't have detectable or some amount of micrometastatic disease or something that was.
Yeah. I think in the adjuvant setting, we know that we're over-treating patients. It's just we don't know who's going to relapse. And so ctDNA may be one of the ways to help us identify those at higher risk. So in summary, nivolumab improves DFS in the intention to treat and PD-L1 positive populations, and it looks like there's a trend to that improvement also being for OS. But the studies were not powered to really determine the efficacy in upper tract patients. And then just kind of putting all three of these trials together, for Checkmate 274 and Ambassador, you had positive DFS, with Checkmate trending positive for OS. Ambassador was negative for OS, again with the caveats that we talked about, and then IMvigor010 was negative for DFS. So what are some of the future directions and ongoing trials in this space? I'll talk more in depth about this ECOG-ACRIN trial, but here listed are open trials that are currently accruing. Nautical is a phase 3 trial, really a feasibility looking at comparing neoadjuvant to surgery versus surgery compared to adjuvant. They're looking to accrue about 14 patients. INDUCT is a trial going on in France. It's a single-arm phase 2 trial looking at adding durva to neoadjuvant chemotherapy. There's a single-arm study that's open at Memorial looking at neoadjuvant EV. And then there's also this trial looking at a PD-1 inhibitor with a HER2 ADC that's open in China, where patients will get neoadjuvant therapy, surgery, and then adjuvant immunotherapy. What's going on now with ECOG Akron is, I think, a really interesting study. It's a combined phase 2, phase 3 trial. The phase 3 element is looking at randomizing people to receive neoadjuvant chemotherapy either with durva or with chemo alone, and then having surgery and following. And then there's a phase 2 component that's a single arm that's looking at the cisplatin ineligible population. And so again, patients are going to receive gemcitabine with durva. So in conclusion, upper tract is difficult disease to diagnose, stage, and treat. There's clear DFS benefit with the use of adjuvant platinum, and that comes from the POUT trial. And the AUA gives this a strong recommendation based upon grade A evidence. There's also compelling phase 2 data, which indicates neoadjuvant cisplatin is tolerated, it does not delay surgery, and 2/3 of patients show downstaging. And the AUA gives us a strong recommendation based upon grade B evidence. And then finally, nivolumab is FDA approved in all high-risk patients, including upper tract, based upon a DFS benefit. And this is a conditional recommendation based upon grade B evidence. Thank you, and I'm happy to take any questions.
Hi, that was a really great talk. So I have a sort of theoretical question about the neoadjuvant group.
Mm-hmm.
So you show that they have a complete response, that the 100% survival, right?
Mm-hmm.
So the question is, what's the role of surgery in those patients? Is the surgery necessary? I mean, I've had a few patients that, I look up afterwards. Imaging is negative, uroscopy is negative. They have surgery, and there's no disease. I kind of feel bad about that. Maybe. So I'm curious what you and the panel think about that.
Yeah, I think it's a really good question, and if there's a window for organ preservation, I think it's just hard to know which patients are going to be in that 20% that have path CR. Maybe ctDNA can be helpful, but that's not. I don't think that's the be all end all. I think that there's probably a role for exploring organ preservation, but I would be hesitant to do that outside of a clinical trial, and would only I would have to have kind of in-depth discussions with my patients before pursuing that. I don't know what the rest of the panel would think.
Yeah, just to briefly address it, I think it's a really difficult question. It's always hard to have that YPT0 patient where you have no cancer and they ask was it necessary. I would say that a couple things. Number one is when the pathologists are doing their pathologic evaluation, they're only taking samples from areas. If they can't see any cancer that's there, they can easily miss something, right? So it doesn't mean just because they're YPT0 on pathology doesn't mean that there was no cancer. It's just it wasn't discovered because there's nothing for them to sample specifically. So they don't even know where the cancer was before it started. So maybe if they had a better way of sampling, that might help. The other is you can draw from some of the data, some of the historic data for, say, cisplatin-based chemotherapy in patients with bladder cancer. Harry Herr published a paper years ago looking at bladder sparing in that patient population. And what ends up happening is that even though they are CRs, so they're complete responders clinically, many of them will relapse. And when they do relapse, they relapse with high stage disease and they're incurable. So there is a scenario in that group where he has tried bladder sparing in patients and been successful in a proportion of them. But when they relapse and they recur, they're often incurable at that point. So the stakes are sometimes a little bit higher in the kidney because, as we showed before, these cancers can be very aggressive, and once that happens, they often relapse pretty badly.
There's also You know, to Jonathan's point, you know, I think the Fox Chase group published on their the Ziebelman paper from a few years ago where they gave neoadjuvant chemotherapy and then did biopsies for PT0 status, and then they correlated them with final cystectomy, and they found that their mapping biopsies were not so accurate for even for bladder cancer to actually know that those patients were truly T0. So I think it's hard. I think it's hard to know whether radiographically in biopsy T0 is really T0 at the end of chemo.
So I get the role of batting cleanup here. So, I think the questions have been great, and thank you everyone for your time. I'm going to go over this last section, which is going to be the surgical management of patients with upper tract disease, and this is all really case-based as I go through this. So let's talk about a patient like this. So this is a typical patient who might come in, 68-year-old, former smoker. He's multifocal low-grade tumor in the right kidney. His cytology is positive for high-grade cells. He has no other significant medical history or comorbidities. His EGFR is poor. He's only got an EGFR of 44. And his right kidney shows a filling defect with hydronephrosis. No invasive features, and his CT scan and nodes are normal. So, questions for you. First of all, looking at this tumor, getting back to Dr. Truong's point before, who would call this a papillary tumor? Raise of hands. Papillary tumor in the ureter? Sure. In the upper tract, in the renal pelvis, papillary? Who would call it sessile? Okay. How about obstruction? You think there's obstruction in this kidney? Raise your hands. Obstruction? Okay. No obstruction? Looks okay. All right. Would you consider endoscopic management? Who would think maybe with this low-grade appearance, low-grade biopsies, high-grade cytology, maybe not such a big deal, low-grade? Who would go with endoscopic management in this patient? Anybody besides Dr. Rahman?
Even I.
Jelmyto, you've got low-grade. We talked about multifocal cancers. Would this be a good case for Jelmyto? Anybody? Yeah, that's the purpose of this case. So the question was, if you have a low-grade biopsy but a high-grade cytology, which one do you believe? So I'll go into that in just a minute. That's a great question. That's the crux of this case. So I think you've got a mismatch here, and this is an issue of sampling error. And this is, I think, a little bit of what Dr. Truong was talking about before, and that's how do you get biopsies, how do you get good quality biopsies, and what do we do? This patient's biopsies were taken, and it notes here, were from the ureter, right? From the biopsies of the ureter. Why? Because that's easy to sample. So any of us would say, I can put a basket on that or get a good piece of that. That came back as low grade. But you look at that renal pelvis and you say, there's something a little bit more going on here, and the cytologies are positive. So that's an important point. Is the imaging okay? Would anyone want to do more imaging? More imaging for this patient? Would anyone get a PET scan? Okay. Would anyone think I've got to send this patient for neoadjuvant chemotherapy? Couple hands. Okay. So the guideline statement. So where does the guideline land for some of this? So one of it is that patients should evaluate. We should be evaluating patients with suspected disease to obtain biopsies, but specifically to get cytologic washings. Right. We talked about that earlier on. I know that came up. Who would get a cytology? We all raised our hands. The reason you get a cytology because you need additional information. Biopsies are not the end all and be all for this disease. We know that we miss cancers because of this issue of sampling and the opportunistic sampling that we use in these cases. And then following these standard assessments, we should risk stratify patients as low or high, and we talked about this already. So where does this patient fall? So you might say, as you said before, well, this sounds like low grade. He's got low grade cancer, there's no invasion, the nodes look negative, it's multifocal. So I'll say that this is low grade, unfavorable disease because of those features if you ignore the cytology. But in reality, the cytology adds data here. There's high-grade disease based on cytology. There's obstruction, based on imaging. This is multifocal disease, and this is not papillary tumor. It is papillary in the ureter. That pattern is called an inverted papillary growth pattern in the ureter. But in the renal pelvis, that's sessile disease. So, in fact, if you use this table properly, you would recognize that this patient falls into the actual high grade, high risk, unfavorable category. So that is a section where you would think about giving neoadjuvant chemotherapy. So this just gets that issue of of opportunistic sampling and the cytology, appearance, and imaging. They add important clinical information to this patient's care. So we talked about endoscopic management. No. Jelmyto, it's not labeled for high-grade upper tract disease. So even though the biopsy was low-grade, this patient has high-grade upper tract cancer. Imaging, yes, it's fine. Would you get a PET scan? Only if you had something like a node that you thought was suspicious, if there are some shoddy nodes in the rectoperitoneum that don't quite rise to the level of something that you would get a biopsy for, you might think about getting a PET scan. Neoadjuvant chemotherapy, the problem in this patient, he's not cisplatin eligible. So what would you use next? And what would be there? Well, there could be some alternative regimens. We didn't get that question, asked before, but some people would say, well, there is a labeling indication for pembrolizumab in patients with advanced unresectable disease, and this patient could potentially fall into that category based on their other risk factors. And there are some clinical trials that are out there that this patient might also be eligible for. At our center, we have a single-agent EV trial that was mentioned earlier. So we would recall this patient as, now we understand this is high-risk, unfavorable disease. We have a category for this patient. We can now talk to each other about what this patient has. So now I refer my patient to my colleagues and others. They understand what's going on because of how I classified this patient before. We decided to get a renal scan to see what the level of obstruction was, and this patient turned out to have high-grade obstruction or moderate obstruction in the right kidney. In fact, it was pretty severe. We put a stent in him, and guess what happened? His GFR actually improved up to 64. So now what? Does this change your thinking at all? Would this patient now be a candidate for getting chemotherapy? Anybody would think about giving this patient chemotherapy now? Yeah, so there's an opportunity now to give this patient chemotherapy just by simply decompressing the kidney. Optionally, you could put a nephrostomy in, and we've done this in patients who've had, say, a prior cystectomy, and it's difficult to put a stent in to try and decompress the kidney. It can be done, they can do nephro-U stents, but typically a nephrostomy will work. He ends up getting split dose gemcitabine cisplatin, and then 2 weeks afterwards, he now comes back and says, okay, got my therapy, I'm all ready to go. What are my treatment options? Where do I go from here? So who here would recommend robotic operation for this patient? Robotic nephro-U. Who would say really open surgery is the way to go for nephroureterectomy, that there's really no role for robotics or laparoscopic surgery, that this patient should have an open procedure? Anyone just open? At my center, I have a number of colleagues who would say that open surgery is the way to go. So there's no right answer here, I don't think. Node dissection, who would do a node dissection in this patient? Everyone agree a node dissection should be done? Does anyone feel like it's optional to do a node dissection? Okay. If you did a node dissection, what should be the extent, and how do you handle the ureter? Does anyone here do an early clipping of the ureter? In other words, when they go in, do they clip the ureter early on? Yeah. Anyone just go right, they do clipping at the end of the case, clipping right before you take the ureter off the bladder? Depending on the position. Yeah. And for ureterectomy, the approach. Anyone here does an intravesical or transvesical approach for the ureter for distal uterectomy? Transvesical? How about extravesical approach? Okay. And show of hands, who uses mitomycin or some type of topical therapy in the bladder routinely after nephro-U? Anyone who never uses it or rarely uses it? Okay. Yeah. Yeah, it's a good. I'll get some of that data in just a second. So the question was, when do you use it? After the surgery. That's a very good question. There's not a lot of strong data one way or the other, but I'll go through some of the data from the ODMIT trial in a minute. So lymph node dissection. So in the guidelines, there's essentially there's sort of the low risk patient and the high risk patient. Low risk would be the low grade patient with cancer that maybe is a bulky, let's say low grade or low risk unfavorable patient who's going for nephroureterectomy. I think in that setting, the guidelines state that it's really optional in that circumstance, that there's not a lot of clear data showing that there's a benefit to doing node dissections in patients with low grade disease. But for patients with high grade disease, there is some compelling data to suggest that node dissection should be done. These are the node mapping templates that have been developed by a number of different centers. This is from a paper that we published collectively between MSK and MD Anderson. It's rare that we ever collaborate on anything, but we collaborated and we fully agreed on this as far as node dissection templates in terms of right versus left-handed sides. And I'm just going to go over that in a little more detail here. So the recommended node templates, if you have a renal pelvis tumor that's in the renal pelvis predominantly, then really you should be doing great vessel dissection around either the periaortic or paracaval nodes on the ipsilateral side, and that can include pre-great vessels, so pre-aortic or pre-cavals, depending on which side that you're on. If it's in the proximal ureter, it's very similar to having it in the renal pelvis, but also needs to be extended down below the level of the IMA. On the right side, that would be down to the bifurcation, same on the left side, so below the IMA to the bifurcation of the great vessels. And then for any tumor that's in the distal ureter, you should also include pelvic nodes along with that. If it's isolated only to the distal ureter and you're doing, say, a distal uterectomy, you don't need to go up and do a full RPL&D, but you can do an ipsilateral. You should do an ipsilateral pelvic node dissection. Here's the data from a large meta-analysis that was done showing this pretty strong, compelling data, albeit from retrospective data, but that the concomitant use of node dissection at the time of surgery can have a beneficial impact on your patients in terms of long-term outcomes. Probably, and the data we've seen from some of those data sets, including SEER data and even large single institutional series, suggests that it's really for small volume nodal disease. If you have big bulky nodes, an extensive RPL&D is unlikely to help your patients. As far as ureterectomy and bladder cuff, so when doing an FRU, you really need to take the entire ureter out. You can't just do sort of a pluck technique, cut it off at the outside of the ureter or outside the bladder and just hope for the best. The chance of recurrence is extremely high in those patients. Well over 35 to 40% will recur typically within a year, and many of them recur at a very high stage. So the entire ureter should be excised at the time, and the evidence level is fairly strong. And then the use of intravesical therapies after an FRU is also highly recommended. This is the extravesical approach that we employ at our center. Essentially, this was actually a paper that I think Indy Gill had put together, but we often will address the kidney first, so the nephrectomy being done first, the ureter being left in situ and taken en bloc all the way down to the bladder. We then develop the ureter. We always clip the ureter early and then put a purse string suture around the distal ureter. We empty the bladder fully at the end of the case, so a Foley catheter is placed. We actually irrigate and wash the bladder out, and then we close it with a watertight closure. As far as adding mitomycin into the bladder afterwards, this is the ODMIT trial. This was a trial giving mitomycin into the bladder. To answer your question, this was actually done a week after surgery. So they had done the nephrectomy, the FRU, they placed the catheter. When the patients came back to get their catheter taken out, that's when they gave the therapy. Most of us are now doing it actually at the same time, on the day of the surgery or the day after, through a catheter. So I think the watertight closures that we're now getting with surgery allow us to do this usually within the first 24 to 48 hours. Jay, are you doing it right after surgery in your center, or are you doing it a week or so later?
I actually do it intra-op.
Yeah.
So, when I put the catheter at the beginning of the bladder, I empty the bladder, I put gemcitabine in, and then I unclamp it. I clip the ureter, and once I clip the ureter, I unclamp there. So I use it intra-op. I don't know what Hong does.
Yeah, it depends. If they have bladder tumor and I resect the, I actually cysto patient at the time of NU. I've been surprised a couple of times. And then if I do the TURBT, then I'll put chemotherapy in before I open the bladder cuff. But if there's no bladder and tumor, and there's no tumor in the bladder, then once I close the bladder cuff, I put in the chemotherapy.
Yeah, in our center, we put a catheter at the time of the surgery for an FRU. Patient comes off the table, and then usually either in the recovery room or the next day we'll do it. And we're actually taking the catheters out within 48 hours after surgery, so we usually do it before the patient goes home. Some people asked about, was discussed about gemcitabine versus giving mitomycin. Well, this was a randomized prospective trial that was done, published back in 2010. Comparing mitomycin to gemcitabine as an intravesical therapy. Now, this is, again, extrapolated from the non-muscle invasive bladder cancer literature, but it showed very clearly that they're at least equivalent in terms of the outcomes, in terms of, of controlling disease in the bladder. And in fact, in this trial for bladder cancer, it showed that gemcitabine seemed to be better. They had a better outcome as far as recurrence-free survival in patients following TURBT, a complete TURBT, followed by intravesical gemcitabine versus mitomycin. Importantly, 2 other points were brought up. One, much better tolerated, and significantly so in this trial, which is actually a pretty small study to find the significance of this level, and also much cheaper. So it's a much cheaper drug to use. So we use it instead of mitomycin at our center, and this is the drug dosing that was used in that trial. So we talked about robotic versus open. It's here. So the data is equivocal. We did a full analysis of this through the guidelines and essentially did not find any compelling reason why robotic or laparoscopic surgery could not be used for patients with upper tract disease. There are certainly, what I would say is go with what you know. If you feel more comfortable doing an open case, do it open. If you feel you're confident you can do a good job with robotic or laparoscopic, then do it that way. But do what's best for the patient, not necessarily something that you feel like you're trying to push the limits on. Should you get a node dissection? Yes. We did one from the cava to the common iliacs. As far as handling the ureter, we always clip early. It's mostly expert opinion, but there is some data that's published out there. A formal bladder cuff should be done, and then we gave gemcitabine afterwards. So this is just a quick video of the case, this particular case. So we clip the ureter. The first thing I do is I come in, I clip the ureter by the iliacs. I then start in right away with the node dissection, so I'll use that opportunity to then start taking down and doing a split and roll. And in this case, we go over to the intra-aortocaval. So we're splitting and rolling along the aorta. I will clip the artery at the intra-aortocaval location. This is stripping the nodes off the paraspinous muscles posteriorly. We'll split the cava on top the cava, and then I'll leave that node packet, and I'll actually pull it out from behind the cava from behind. I've already clipped the artery to the kidney, so the kidney is no longer making urine, so I don't have to worry about that anymore. And then once I've freed up the retrocaval nodes from behind, I'll then pull the packet out on the opposite side. And I don't send these off separately. I actually take them out en bloc with the kidney at the end, and then I dissect them off at the end of the case and send them off separately to pathology. I'll put a purse string suture in. I think a lot of us are doing this now around the ureter. I like to put some Surgicel down as a little bed to put the ureter on at the end. I'll clip the ureter just outside the bladder before I open the ureter and open the bladder. You want to open in the anterior part of the bladder first because that allows any fluid inside to drain. The gas will get into the bladder and push urine out of the bladder so it's fully empty. I then will drop this on top of my little Surgicel bed. I'll wrap that up. I'll close this up, and then I'll close an additional 2 or 3 layers on top of that. And then that usually allows me to get the catheter out within a day or 2 after their surgery. And those patients will typically get their mitomycin or get their gemcitabine in the PACU or on the floor the following day. He went home. He had a YPTIS, which means that's post-chemotherapy. He had CIS. It's important that you know that CIS does not respond is not known to respond to cisplatin-based chemotherapy. So it's not the type of disease, if you find CIS in the upper tract alone, that you would treat with neoadjuvant chemotherapy. You really need to have high-grade cancer by itself to treat with neoadjuvant chemo. Do you have concerns about residual disease? The answer is, how do we follow this patient? Well, according to guidelines, as Dr. Rahman pointed out before, this patient should be followed with endoscopic evaluations done at a routine interval, typically every 3 months for the first year. That 9-month window is optional because bladder recurrences are very common in patients after nephro-U. Roughly about 30 to 40% of patients will recur in the bladder after nephro-U, so you have to follow and monitor for them for that. This pathway does not mean that if they've recurred twice in the first year that you get to past 12 months, you can now say, oh, I'm only going to follow them every 6 months beyond that. If the patients are recurring in their bladder, you have to continue to monitor the bladder until the bladder is clear and then go on from there. Cross-sectional imaging and then lab studies as appropriate. So this is a 62-year-old woman now with a tumor in the lower ureter. She's got a tumor down just at the pelvic brim. She has a family history of endometrial cancer, gastric cancer. She has an excellent GFR. She has a mass below the iliac vessels and significant left hydronephrosis. But there's no pelvic masses, no renal pelvic masses, and her chest and her nodes are normal. So would anyone do further studies in this patient? Is there something more to do? You've got a CT scan. You've got a good quality CT scan. You've got a good retrograde. You've got biopsies. Is there anything further that you need to do for this patient? Any further studies of any kind? Yeah. So testing for Lynch syndrome, sure. She's got a very strong family history. She's got endometrial cancer, gastric cancer in the family. Absolutely, you think about Lynch syndrome in this patient. You might not have to wait until the results come back, but she does have a history that's very strongly suggestive of that. Her management discussion, We offered her distal uterectomy. So instead of going for nephro-U, we said, look, you've got Lynch syndrome, you've got an obstructing tumor in the distal ureter. Even though the biopsy may show low-grade cancer, the fact that it's obstructing means that there's probably something more going on here. We offered the option of going in endoscopically and treating her that way, but with a case like this and knowing the long-term follow-up that she was going to need, she felt more comfortable going ahead with distal uterectomy. We talked to her about the lifetime risks of doing endoscopic management for something like this and having to go back, and she said, you know, I'd rather just have this reimplanted and have it done in one shot. We did send her for genetics referral, and the question about giving her neoadjuvant chemotherapy, I think in this setting, if you're not going to be affecting her kidney function postoperatively, she has excellent preoperative kidney function. We're not taking her kidney out. So the issue of neoadjuvant chemo in that setting doesn't necessarily apply. We can wait for the pathology to come back in this case and then decide based on that pathology whether adjuvant therapy might be an appropriate approach in that setting. So she underwent a distal uterectomy and a reimplant and did a 3-layer closure of the bladder. The pathology did come back PT2 disease, okay, high grade in a background of low grade cancer that was invasive. Her margins and nodes were negative. And so afterwards, now we referred her to medical oncology to talk about adjuvant therapy in this setting, a la the POUT data, right? This is a T2 tumor in a patient with Lynch, and we sent them for adjuvant. Her kidney function was not affected by the surgery, and so therefore we're not worried quite so much about this issue of platinum eligibility. So people often ask me, does everyone have to go for nephro or for neoadjuvant chemotherapy if they have high-grade disease? And I would say if they're going to have normal kidney function after their surgery, if you know that it's going to be normal, it's not going to be effective, then no, I don't think you necessarily have to. The advantage of giving it in the neoadjuvant setting is because of the kidney function, which is so important in these patients, to give them platinum-based chemotherapy that's effective. Carbo is not quite as effective as cisplatin. In this setting, though, this patient's not going to have that problem afterwards. The other advantage is in the adjuvant setting is that you have the pathology. We talked about over-treating patients. Some patients with high-grade upper tract disease may not have T2 or greater cancer. They might not gain a big advantage from getting the neoadjuvant chemotherapy that you're giving them, and you may be harming them in some way by over-treating them. In the adjuvant setting, you have the pathology. You now know what their pathology looks like and whether they might be at risk and might benefit from it. So her follow-up, we've been following her now. In my patients, I do follow them 3, 6, 9, and 12 months. These patients want to be followed very closely in this setting, so I do it every 3 months, even if the cancer is not coming back. The advantage of the ureteral reimplant is that I can actually scope that patient, and even in the office, in the reimplanted patients, I'm often able to even pass the flexible cystoscope all the way up to the ureter and monitor the upper tracts in the office. It's surprising, but you can do it. And patients tolerate it quite well. CT imaging, as before, and her Lynch testing came back positive. So, summary take-home messages. Node dissection should be performed for high-risk disease. You really should be doing it, and the node templates that are described give you a good basis in terms of what nodes to remove. We don't think about node counts. Don't go in and start plucking out nodes individually to try and get to a magic number of 10. Take out the nodes, in the distribution that they are, and just be careful when you do so, because there can be complications associated with those procedures. As far as bladder cuff, you must take a bladder cuff in your patients. You really should not be doing a clipping outside or the pluck techniques. Those have been shown in long-term follow-up to be a problem. Installation of intravesical therapy after nephro-U should definitely be performed in your patients to minimize the risk of recurrence whenever possible. And then testing for MMR genes of all patients with upper tract disease is important. So how are we doing on time?
At time.
We're at time. So I'll end it there, and I'll just leave you with one quick little thing for the future, and that is that in patients with Lynch syndrome, we're now giving PD-1 therapies afterwards, and this issue of complete response that you asked about before is now becoming a reality in patients with this particular disease process. So more to come in the future in terms of future directions. Any last minute questions? Yeah. Adenocarcinoma of the ureter, yeah, complete. I've had very limited experience. It's rare, so variant subtypes in the upper tract are rare, much more rare than we see in bladder. Typically don't follow the same pathways that we have here in terms of the variants that are there. They don't tend to respond to chemotherapy as well. Another question.
Is there a commercially available MMR test that you refer to?
Every single lab in the country can do it. So what's interesting, and this is a very important point, for every patient with gastric cancer in your hospital, they're already getting MMR testing. It's mandatory for all patients with every gastric cancer. Every woman with endometrial cancer is automatically getting MMR testing in your pathology labs because of this risk factor. It's also recommended there. Same is true for patients under the age of 50 with colorectal cancers. And so it's already mandatory by guidelines, by the GYN literature, by the colorectal surgeon literature. We are just now including it in the GU literature. If you were to take every woman with endometrial cancer and do MMR testing, the percentage of patients you'll find with Lynch is 3%. If you do MMR testing in every patient with gastric cancer, 3% have Lynch. You do MMR testing in every patient with upper tract cancer, 9%. 3 times higher, chance of having Lynch syndrome in upper tract cancers. So it's really important that you test.
So if the pathologist asks, you just say
Pathologist
MMR
says,
test?
you tell them it's a guideline directed now, and you should be doing it for Lynch. If they're doing it for gastric cancer and they're doing it for endometrial cancer, they should be doing it for every patient with upper tract cancer.
Thank you.
Thanks. Thank you for your time. There's a post test. You can take that separately outside, on the app, and we'll check and see how you do. And if you like the course, please let us know, and we'll be able to keep it again for next year. Thanks so much.
Well, it's because you're controlling it, so.